in my rush, in my last presentation, I skip over a short little video, 3 minutes or so. It really changed my view about how, what contribute to a person's health as an issue. This particular computer science professor from Cornell opened my mind up about small data versus big data. Now, you've heard it many times, and I understand that the ministry is very focused on getting big data, pulling data from all our EMRs in order to try to come up with healthcare solutions. In Ontario, I guess it's part of the Canada landscape. The government agency that I work with, one was honest enough to tell me, when they pulled our OSCAR data, and they have the entire database, it takes them something like more than 200 algorithms to determine if a patient actually has diabetic or not. I mean, there's just so much stuff in there. You pull them from billing, that's useless. Pull them from lab tests, that's pretty, our problem list, it's hit and miss. You just name it. So the idea of big data is good. It's, I would try to suggest that it's not. And so before I actually go into the so-called NextCloud 2.0, OSCAR 2.0 NextCloud, it's really about transforming our whole idea about looking at the whole ecology of things. I learned the ecology from my friend Joseph here. What does it look like in the future, right? I like to think that this OSCAR is a great start because it forms the ultimate test platform for what I'm proposing, what the future should look like. You would almost always be working with an administrative electronic medical record system as an organization. But mostly your interaction with patients and what contributes to a patient-centered care also rests on the patient's control and input into their own personal health record. Now, like I said, this is a little more than 3 minutes. I think it's a very, she explains it better than I can.
This technology is making use of devices we already have in our pockets. I am Deborah Estrin. I am a computer scientist. I am focused on the design of open source platforms that leverage mobile devices and other sources of data to address socio-technical challenges, things like personal health management. Several years ago, I coined the term small data, by which I mean using the digital traces that we as individuals generate online and on our mobile phones for ourselves, using our digital traces to help answer the question, how are we responding to a new medication? How are we responding to a new form of physical therapy? How are we generally doing as patients? The term big data is widely used, and it's a really important movement in the world of business and medicine and science. Big data has to do with using large-scale data from large numbers of individuals, whether those individuals are patients or customers, people reading the New York Times. Small data is not instead of big data. It's to complement it. Because if you look at an individual over time, we're all quite individual or even idiosyncratic. And the way we respond to a medication or to treatment or to medical advice is very different one person to the next. These small data can be processed into what we refer to as digital biomarkers. And those digital biomarkers, just like a blood-based biomarker, can be used to give very important feedback to the clinician on how you're responding to care. What's the state of your condition? The small data that are turned into digital biomarkers are very intimate pieces of information. It's things like, where are you at every moment of the day? What's your tone of voice that you're using in various phone calls? How stressed are you? So when we design these systems, we design so that the private information stays private and the relevant information actually is shared. The work that I've been doing in small data and mobile health emerged out of my research center that I had run at UCLA on embedded network sensing, and in the middle of that, smartphones emerged, and they became an increasingly interesting kind of a sensor, particularly as people carried them through the world, and then particularly as they became these constant observers of that human's behavior. What this award means to me at this particular point in my career is it really gives me license and impetus to dig in, not to step back or take a back seat or to slow down.
This little speech she gave when she won an award from MacArthur Foundation. If you search online, she has another video to talk about her own father, went through the last months of his life, and gazillions involvement with the formal healthcare systems. Nothing worked, and he died. And then she told a story of how she, looking at all the little biomarkers, the way that she used terms like, you would have predicted, him having a hard time a year or two before his Facebook usage, and like exactly the way she's talking about. So what she's encouraging me, anyways, is that we don't have all of those biomarkers, and it's got to be a work in progress. The way we understand, how we interact with the world. I think of myself. When I say this, people always say, you're a bit weird, talking about it like that. Like when you tell me a primary prevention in my age group, let's say, should I take cholesterol because I did a blood test? I said, in 10 years, the probability for me to be alive is less than 50%. Like, don't tell me that cholesterol is an important part of in my little concept of health, right? Now I kind of lost my footing in my NextCloud, so I'll get back to it a little bit. My experience with NextCloud is that it began as an alternative to big tech with focus on privacy of all my data. I like to think that the little NextCloud server you saw, it's in my basement, it's running off eBay refurbished machine. You can get one of those for $120, and I stick a 2 terabyte little digital hard drive in there, and I have a couple of even cheaper cast outs. They're continuously backing up that thing. Yeah, and I have a little condo in another city. Every week when I go there babysit my grandchildren, I take a backup copy of it. Talking about somebody who's a little anal, I'm kind of one of them, right? And I like to think that when my grandchildren someday would want to look at what the grandfather is like, I'll try to read my 300, blogs. I think they would learn a lot about me because I spend the time trying to, writing is not my strength, and I'm just really going to try, right? So, but it speaks from my heart. These things would never end up in your system. No, there are certain things that are so sort of important. So you begin with a system that the creator, who's also very smart people. They're totally committed to open source platform, knowing that people are going to put apps. There are right now over 300 apps in there. And one of them is called EHR. Lo and behold, it's designed for interoperability. It integrates. You can don't even bother to migrate your Google Drive. You can actually on this platform can go back and forth on your drive in the background using all the industrial strength interoperability security features. I mean, it's all built in. It's part of their life. That's why they're they're so good in replacing governmental systems, and we're talking about very large systems. So they continue to draw income from these other sources. And I've been with them for several years now, and I don't see like forks and, you know, people running off and do things. I mean, it's got a very large following. I mean, I've installed them as little as a Raspberry Pi. It'll work on a Raspberry Pi. It will work on, you know, big mainframe, but you can imagine, you know, running a government. They don't ever do cloud-based system. They call it on-premise, on-prem. You know, if you know, they just had a big conference in Germany, I think, on Tuesday, and I went in. They're in version 5. You know, they're progressing, getting more and more. You know, all the extra the development. It's just continue with what they started out with, except that now they would laugh about it. This one looks a little bit like Microsoft. This a little bit look like Google. But they would just do what works for them. So just Google NextDrive, download. If you already have a Ubuntu system of some sort, or even Microsoft or Mac OS, you can install NextCloud just like that. Okay, and so it's worthwhile looking at it. Now, so in the story, you talk, you know, so the idea is that you have these platforms. We don't know what future is like, and neither do we, but we don't admit it. You know, when we design measurement, for example, I know, John, you're going to talk about it. It's a bit of a what do you call it? You know, like it's going to turn. We design with 4 characters for the measurement ID. You can't. How stupid were we, right? But things are going to evolve like this. Like, as long as it remain a personal health record, there will be somebody who is going to say, you know what? The old days, you were showing me a bunch of blood pressure numbers. No, I'm going to have a time series. You know, this is the biomarker. It's way more important than a static blood pressure. Whether you do it with a cheap $25 cuff, or the doctor who meticulously look at the mercury and listen for this sound that I have never learned to listen to, where the cutoff should be. You can do, you know, there are people who theoretically look into the idea of a piece of data carries with it so much metadata. And where was it? And what does it really mean? And how does it really impact on others? Now, we've got so much more to learn, right? And so I'm suggesting that you begin with something like the EHR level of an app. And I'll show you. It connects to the back end, to the Hospital for Sick Children's FHIR server to try to codify your number when you enter it. And it's coded to already, you know, some of you were in Earl's session, and he talks about FHIR as a HL7 subset of standards that allows it to move forward. The more metadata or the qualifier information about the piece of data you put in, the better. But it's not always possible. You're busy, you're rushing people back and forth. So you let the patient who is interested in this, because ultimately it's for the patient, right, for themselves. And they would organize it in a way. Somebody is going to have, if there's an idea, there will be an app, okay? And you might even be able to sell it for a few bucks. I would love to have somebody who look at my entire NextCloud and come up with a cumulative patient profile, so that when next time I wake up unconscious, I don't have to tell the same silly story to about 4 or 5 different people. Have you ever been sick in the ER? First, the nurse comes in, and then the intern, and then the resident. The resident did the best job. Actually, I did an examination. All the other got in and out, in and out. And if you ever look at my hospital record, I would say it says very little about what happened, actually. Think of all the healthcare dollar we spent, right? And I'm saying that for developing a community, if any of you work for the government, please go back and talk to the InfoWay people. Like their blueprint is a complete joke. The hire later, and everybody had to pull all your data into this. You know, it makes me remember a certain characters at hire. It does not get anywhere. Okay, and here I am showing a little bit of my frustration about just the wrong focus. And so where am I here? I do have a few slides about. Okay, now let me just go in here. Any question? I mean, this given this time is your. Maybe you can share your view about what. Okay, yeah, I just only had a few slides. So, and even with this one project, you always begin with someone. That person, I think from Germany, is not too clinical. I mean, he just did all the right thing. It allows me to put in my file server reference, which is from Hospital Sick Children, and then I started fiddling around how to integrate with OSCAR, and then how do you integrate with something like Kindred, PHR? How do you integrate with K2A, piping in, and how to integrate with my little Pico W, the Pico pipe. It's this little guy here, less than $20. They can do so much, it's unbelievable, right? And all the data would pipe into the NextCloud. NextCloud, there would be an app that would try to pick up what is most relevant for a certain occasion, like when you show up in a merge. You can give access to NextCloud temporarily for only a piece of data. And I suggest that we all could work on the cumulative patient profile as a start. It would have improved our interaction with the healthcare system tremendously because it's consistently the same document, okay? And it tells the story and what is important to you or not, right? So you can work on this right now, right? And if you think you need help, I ask OpenAI, for example, this is the exact statement. I say micro Python code to read CPU temperature. It could be whatever, your weight, whatever device that you're using, and send to NextCloud, okay? And the board I use is an $18 board. It picks up the sensors, and then it tells you, okay, this is how you do it, okay? It gives you a generic thing. In my case, it would be my oscarservice.com and whatever. And you put username, password. Now, this is the lowest level of interaction you can put in. But you can actually write code to go through the OpenID, OAuth 2, to try to keep the interaction even more private. Most of us don't really care that much because I'm doing it in my house anyways, right? My data travel in my own little world. It just goes from a device into my server, all without connecting to the internet. I'm judging from the look of your face. Maybe this isn't exactly clear. In the world of this internet connectivity, okay. And then okay, since this thing here you have to use Wi-Fi, it's the easiest, so you don't have to have so many wires in the house. But every one of these is totally capable of doing this. And then you go to the next one, and you say microcode. How to connect it. It gives you how it's all done, and it's all there. And you run it. It converts the temperature using mathematics into some basic reference point, and then there you go. I mean, OpenAI can actually do pretty good coding, all right? Now, this you would say, okay, what's this example? It means nothing necessarily, not yet. And the whole NextCloud idea is not yet, but we're at least building little Lego blocks, achieving something that is relevant and that is more important to me. You can keep pouring more money into all kinds of data integration projects, like the Canada Health Infoway, $1 billion, what have they done? Apparently they managed to standardize the diagnostic imaging across the country. Because the story of the Infoway CEO is that when he travels to PEI, his grandmother got sick. Wouldn't it be so beautiful that, you know, she's from Vancouver, that she has everything they need there to look after her. It just does not exist. Okay, you can afford another $1 billion. It's not going to happen. But try something small. Try to start teaching personal health, giving people ownership of personal health record. Start encouraging all the programming schools. It doesn't take much to learn how to do small programs. As I've learned that it doesn't take, I mean, it's amazing how many of you who are not trained in computer are doing e-forms, and it blows my mind, right? Or Stan here would do Grease Monkey as a test proof of concept of how the interface is going to streamline things for you. But it's a world that's going to be a little different. You know, I mean, I hope I'll live long enough to see at least some element of it. But at least for me, when I next time have a hospital visit, I hope to have one single sheet of paper that tells everybody, don't give me that drug, that would kill me. These are the important things that I want. Don't do this, do that. Right? I mean, it just would be nice. I may be talking to the converted, but you might say, why would my patients care? They just say, you know, give me that pill and get me out of here, right? It may be, but, you know, but if you're going to build something that is worth something for the future, then I think the NextCloud, it's a platform worth looking at, given its, you know, history. It seemed to me reliable enough to put my own energy into it. Is that even helpful remotely? Question, please.
I mean, Microsoft tried it, Google tried it, right? Where Microsoft Health, Google Health, or I forget what it was called,
Yeah.
Google something, and went nowhere, right? I mean, they asked for all kinds of things, and if you have other, you know, how can it start, or what's the solution for that kind of, you know, top down rather than?
Well, I mean, I like to think, you know, I still occasionally think like that Apple would call me tomorrow. You know, I want you to come in and join my team in our health app. Because up to this point, it's like they really need clinical input, you know, researcher type a little bit, but they really need more help. You don't just give people a fancy looking app, but you put garbage in and you end up not really helping anybody, right? But it's amazing. I mean, I most recent project was it's called the home resource. It's an open source project. A little Raspberry Pi, took me minutes, boom, and it will manage all the IoTs for many of the standards. It will pull all the data in one place, inside my own house. Right? I mean, so you would be seeing more and more of these kind of projects evolve over time. There's not a lot of big money. See, that's the thing. The health vault, I have predicted that it would really fail. I think they gave that up, right? Google gave that up. Yeah, you know, health. It's a very complicated. It can be easy, you know. If A, B, do C, right? That's how we were trained most of the time. But it's also a very complex. So I've taught evidence-based medicine for decades now. The one thing I kept emphasizing to the learners is that the EBM is what it is today, but it's grossly abused. They probably skipped the last point that EBM is trying to teach us, is that patient preference matters. And we say, you know, we're trained to look at a lab, only look at the red one, right? And as long as it's below the threshold of normal, you know, it's abnormal, as if, you know, you're going to be dead. You know, so I do this all the time with my residents. They roll their eyes, and I'll try different on you. Okay, don't be embarrassed, because I've done this many times. If I give you a simple, what I call simple, is that most of you have gone through high school, and you should have known it, okay? So if I ask you a question, a baseball bat and a baseball cost you $1.10. A baseball bat is $1 more than your baseball. How much is the baseball? Okay, it's A plus B, 1.1, A minus B, 1.0, 2A, but almost 100% people would say 10 cents. No, it's 5 cents. And the reason I use that example is that if I turn it into a little more complex, okay, situation, a mammogram, 50-year-old came in, mammogram positive. Your heart sank as much as you have to tell this unfortunate news to your patient. And so I put down, the patient is likely to have breast cancer 95%, 80%, 25%. Yes, in your head you have one number. And almost 100% of my residents fail this. It's 25%. So instead of saying, I am so sorry for you, you better get your house in good order. No, for most of us, we love a 75% chance rather than 25%. I mean, but seriously, we're too lazy to go through this. And I get this idea from a book called that has impacted me the most. It's called Thinking Fast and Slow. It's really worthwhile reading that book. And we are unfortunately trained to be lazy thinkers. We don't really sit down and try to work through this. Now I know this always get a lot of emotion going, right? So when I was trying to explain, when I'm totally asymptomatic, and I was told to stick a little thing in my nose, and it says positive of COVID. Well, what is the likelihood that I actually have COVID? You know, and this test is not bad, 97% sensitive, 92% specific, or something like that. It's not bad. Okay, you got something in your head. Well, I'm 5 more minutes, 95% likely of a false positive. You say, oh, come on, it's just not going to be the case. Well, I'm just telling you, for asymptomatic and living in a community, how many COVID on any particular day, you divide by a population, that would be your preference or pre-test likelihood. And if you work that out, all the math, which you cannot do on a piece of paper, that's what it comes up with. I wasn't trying to pull a fast one on you. I'm just saying we jump to conclusion, sometimes to not only our detriment, our patient's detriment. So there are many things that we do. I'm hoping the future is that there will be more apps that are sensible to really take you through, navigate a very complex area, which is called health, and not sickness either. I look after like a hospice, and let's say my mortality rate, I only work 1 week out of 4. Let's say I see 10 patients here. How many do you think I will see again in 4 weeks? Maybe 1. So if I go in and the patient said, but my sugar is too high, what do you think? How do you help that person? Okay. Do you have any symptoms? Are you feeling okay? Any pain? Well, you just, like, people have been taught to completely thinking things through in a wrong way. Classical thing in a retirement home, come in 20 minutes and at the end, they'll be lucky to get 5 left. Because I had to work through this very gradually, trying to explain things and stuff. So these things are harder because you have a general population who are ignorant on this, so are we, and then you try to teach values that are more important to them, or to understand their values, right? Okay, so I hope it doesn't come across as preachy and everything. I mean, I just think about these things a lot, and and hopefully it's helpful.